had to record with my own setup. So therefore, the recording may appear a little less quality. So this chapter is going to be discussing on oncosurgery part, general and soft tissue sarcomas. Okay. So let me start my discussion on oncosurgery, general and this thing. So now, first let us discuss about bony mets. Let us discuss about bony mets. I hope you would have read about bony mets in your orthopedics also. But let us discuss certain basic points which are needed from surgical aspect. So what is the most common bone involved? Most common bone involved in bony mets is vertebra. Please don't forget the most common bone involved is vertebra. Okay. And also, please don't forget after vertebra, in names we can get the questions like what are the order of appearance of various things. No, you can get like that. So in that after vertebra, the common next site is femur. So next site is femur, followed by pelvis, followed by ribs. Okay. So remember as FPR. After vertebra, the order is femur, pelvis, and ribs. And after that, the other rare sites are include humerus. And the least common site is skull. The last one or the least common site is skull. The most common is vertebra and the least common is skull. And at this point of time, you should know what are the types of mets also we get. And what are the types of mets we get also you should know. Let me tell you about the types of mets we get. So about the type of mets in bone, the type of mets, the mets we get are the bony mets can be of two types. They are osteolytic and osteoblastic. So please don't forget, this is very important for your exams. Osteolytic and osteoblastic are the two types of mets we get, and this can be further divided into mixed. The third one is mixed. So most osteolytic, pure osteolytic, which is pure osteolytic is kidney. So kidney mets are pure osteolytic mets. Pure osteoblastic are prostate. So please remember these are two important cancers. Prostate cancer produces pure osteoblastic secondaries and kidney produces pure osteolytic secondaries. Pure osteolytic secondaries. And in mixed, predominantly more of osteolytic. Can you give me examples which are all mostly osteolytic lesions? In mixed, they can get both osteolytic as well as osteoblastic. But they are more osteolytic. They are thyroid, lung, GIT tumors. GIT tumors are more osteolytic, and which are all more osteoblastic. I hope you know very well the answer from this. This question is a repeat NEET PG question as well as James question. The more osteoblastic is breast cancer. Please don't forget, breast cancer is most important, more osteoblastic. Breast cancer can get both osteoblastic as well as osteolytic, and it is more of osteoblastic. Please don't forget, it is more of osteoblastic. And what are the other tumors which will be more of osteoblastic are the following. Please don't forget, seminoma, testis can be both osteolytic and osteoblastic, but there will be more of osteoblastic. Carcinoid tumors are this neuroendocrine tumors and the neurogenic tumors. Neurogenic tumors and gynec tumors, like uterine and cervix tumors, like gynec tumors, all these tumors you can see they are all more of osteoblastic secondaries. They are all more of osteoblastic than osteolytic. So please don't forget, pure osteolytic is kidney, pure osteoblastic is prostate, more of osteoblastic is breast, and more of osteolytic is thyroid cancer. So please don't forget these cancer points. So let me now discuss about some basic syndromes which are asked in oncosurgery. One of the important syndrome is tumor lysis syndrome. You should not forget this tumor lysis syndrome. Very important for your exams. Tumor lysis syndrome. What is this? This is usually happening. This tumor lysis syndrome usually happens following a chemotherapy or a radiotherapy, especially chemotherapy. When you give for the cancer cells will break and they release a lot of important things. So that results in this tumor lysis syndrome. It is mainly due to rapidly destroying cells due to chemotherapy, and this is very commonly seen in conditions like lymphomas, especially Burkitt's lymphoma. This is very common, and also it can be seen in leukemias. In leukemias and lymphomas, the moment you start the chemotherapy, you can get this issue. What happens actually? So please understand this practically. You can get this question repeated MCQ. What happens in this condition practically is, as the cells are getting ruptured, there will be a lot of nucleic acid which will be released. So you all very well know the nucleic acid will be released, and I hope you know the metabolism. From nucleic acid, we get uric acid. So the patient gets enormous amount of uric acid in his blood value. So hyperuricemia, first important point, hyperuricemia will be there. And as the cells rupture, the potassium also is released out of cell. So potassium is predominantly intracellular, that will be ruptured and it will be released out. So intracellular potassium comes out, that is therefore causing hyperkalemia. And similarly, phosphate is also released. Phosphate is also getting released out from the cell. And as this phosphate is getting released out, it will bind with the ionized calcium. It will bind with the ionized calcium, and therefore, please remember, this is a very important point. There will be decrease in calcium, increase in phosphate. Because of binding with the calcium phosphate gets binded out, and therefore the calcium level is decreased in this tumor lysis syndrome. And this calcium phosphate will go and deposit in the renal convoluted tubules, and it can cause renal failure. So they get deposited in the renal convoluted tubule and it causes renal failures. So please don't forget, this is a very important thing. And they also get lactic acidosis. So what are all the features of tumor lysis syndrome? Number one, hyperuricemia, hyperkalemia, hyperphosphatemia, and never ever forget for your exams, hypocalcemia. This is an exception. Usually they give the following features of tumor lysis syndrome except there is decreased calcium. Please don't forget there is decreased calcium in tumor lysis syndrome. At this point of time, let me tell you another one syndrome in which there is hypercalcemia of malignancy. So why I am comparing this? Because in tumor lysis syndrome there is hypocalcemia. Tumor lysis syndrome happens due to release of calcium. So tumor lysis syndrome happens due to binding of calcium. This hypercalcemia of malignancy. What is the main reason for this? I hope you know this very well. It is due to increased release of calcium from the bony mets. From the bone, the calcium gets released. And also it may be due to parathyroid hormone related peptide. Parathyroid hormone related peptide also can cause this, and it can be due to rapid reabsorption by the renal tubule. So there are multiple causes. Main causes due to metastasis, the calcium gets released from the bone. And the main important thing is there is an underlying increased parathyroid hormone related peptide that is causing this increased calcium release. That is the cause of this hypercalcemia of malignancy. So the main difference between tumor lysis syndrome and hypercalcemia of malignancy is in tumor lysis syndrome there is hypocalcemia, in hypercalcemia of malignancy there is increased calcium. So please don't forget these two conditions. So now, what is the treatment? What is the treatment for these two guys? So please remember, tumor lysis syndrome, what do you do? So tumor lysis syndrome, our aim is to prevent the calcium phosphate getting deposited in the renal tubules. Hypercalcemia of malignancy, our aim is to decrease the calcium level. Hypercalcemia of malignancy, our aim is to decrease the calcium level. So what are we going to do? So in both the cases, please remember, we have to do pakka hydration. Aggressive hydration should be done. We have to do pakka hydration, and we have to give sodium bicarbonate in this tumor lysis syndrome. As I told you, there is lactic acidosis happening. So I have to give sodium bicarbonate, and since there is increased uric acid, I have to give allopurinol, which is a very important thing which inhibits uric acid by blocking hypoxanthine to xanthine conversion in uric acid pathway. You'll be reading this in pharmacology and biochemistry. Allopurinol is used to decrease uric acid. Okay, and other drugs include, so ras buricase. Ras buricase is a recombinant uric acid. It is a recombinant uric acid oxidase. So this is also used, and we also use hemodialysis in cases of renal failure. If there is renal failure, we also give hemodialysis. Very important. These are the drugs used in tumor lysis syndrome. You can get this question also. What are all the drugs used in tumor lysis syndrome, and what are the drugs used in hypercalcemia of malignancy? What are the drugs used in hypercalcemia of malignancy? So please don't forget, here very much to again hydrate, but with a normal saline. Enormous amount of normal saline is used, and we can use diuretics, especially furosemide can be used. And here we have to decrease calcium. There are multiple drugs available. You know very well. They are biphosphonates, bisphosphonates. So we can use bisphosphonates, calcitonin. We can use calcitonin. We can use plicamycin. We can use steroids. We can use steroids. All these, even gallium nitrate. We can use gallium nitrate. All these are various drugs used to reduce the calcium level. So please don't forget, what are all the drugs used to reduce the calcium? So the drugs used to reduce the calcium are biphosphonates, calcitonin, plicamycin, steroids, gallium nitrate. These are the drugs we use to reduce the calcium level. These are the drugs we use to reduce the calcium level. So please don't forget these two topics: tumor lysis syndrome and hypercalcemia of malignancy. In tumor lysis syndrome, whatever you forget, please don't forget there is hypocalcemia in tumor lysis syndrome. Please don't forget that point. Okay, please don't forget tumor lysis syndrome. There is
soft tissue sarcoma. It's a very rare tumor. If you see, it's a very rare tumor, and in my practice so far, I have seen only some 5 to 6 cases. It corresponds to only 1% of the adult tumors. So please remember, it corresponds only to 1% of the adult tumors. Just 1% of adult cancers. Various cancers we have now. It just corresponds to only 1% of adult cancers and 7% of children's cancer. It's corresponding to 1% of adult cancers and 7% of children cancers. Please don't forget this basic point. Okay, so 1% only adult. And where does it arise from? It arises from embryonic mesoderm. Please don't forget the site of origin of this tumor is from embryonic mesoderm is the site of origin of this tumor. So you should not forget that it arises from embryonic mesoderm. Then what are the most commons? You should know certain basic MCQs. Though before going to the depth of each tumor, let me discuss about certain basic MCQs. Let us first discuss about most commons in soft tissue sarcoma. So the most common type overall is highly controversial, but please follow by substance, which is very clear in saying liposarcoma is the answer from substance page number 762. It is there at page number 762. If you have it out, you can verify from substance. Please go with substance. It is liposarcoma. It is liposarcoma is the most common, followed by leiomyosarcoma. So it asks you what is the most common site of this soft tissue sarcoma. It is extremities. It is more common in extremities, especially it is most common in lower limb than upper limb. So please don't forget, it is more common in lower limb than upper limb, and it is there followed by trunk and other places. First important site is extremities, followed by trunk, followed by retroperitoneum, and finally comes head and neck. The last is head and neck. So you can get another question in exam. What is the most common site of soft tissue sarcoma in pediatric age group? Pediatric age group soft tissue sarcoma is most commonly rhabdomyosarcoma. Rhabdomyosarcoma is the most common pediatric soft tissue sarcoma. Okay, and this rhabdomyosarcoma in pediatric is most common in head and neck. Head and neck is the most common site of this rhabdomyosarcoma. And you can also get another question. What is the most common site of retroperitoneal soft tissue sarcoma? Most common site of retroperitoneal tumor. Most common retroperitoneal tumor is, again, please don't forget, it is also liposarcoma. So these are typical one-liners you can get in this old pattern, neat pattern question. So please don't forget these basic points. So most common soft tissue sarcoma in previous edition was malignant fibrous histosarcoma. It is no more. It is now liposarcoma. And most common site of soft tissue sarcoma is in extremities, and especially finally, please remember, you can give a differential diagnosis of a lipoma in the thigh. You can give it as soft tissue sarcoma, and you can go into discussion of soft tissue sarcoma also. And in pediatric, it is rhabdomyosarcoma, and retroperitoneum, the most common retroperitoneal tumor is liposarcoma. So next, coming to the most common site-based most common points. What are the site-based? Next, I'm going to tell you about most common type of soft tissue sarcoma. In extremity, what is the most common soft tissue sarcoma? In retroperitoneum, just now I told you what is the most common soft tissue sarcoma, and most common soft tissue sarcoma in viscera. Can you tell me what are these answers? What are these answers? In extremity, it is, just now I told you, malignant fibrous histiocytoma. Was one of the most common soft tissue sarcoma in extremities. In retroperitoneum, it is liposarcoma. In viscera, I hope you know the old term leiomyosarcoma is now renamed as GIST. We have discussed about GIST in GIT chapter. So GIST is the most common soft tissue sarcoma in viscera. Please don't forget this point. And please don't forget, these soft tissue sarcoma has certain characteristic properties in tumor spread. So if this is a lower limb, the soft tissue sarcoma can grow and it can compress the soft tissues around it, and it will form a pseudo capsule. It's not a true capsule. By its compression, it forms a pseudo capsule. Please don't forget, it forms a pseudo capsule. Because of the compression of the surrounding soft tissues, it can form a pseudo capsule. And this soft tissue sarcoma most commonly spreads by hematogenous route. Please don't forget, the most common spread is by hematogenous, and the lymphatic spread is very, very less common. Please don't forget this point. Lymph node spread is very less common. It is in only 2 to 10% cases. It is very rare. So in hematogenous means, where does it go distally? Most commonly means it goes to lungs most commonly. Soft tissue sarcoma most commonly goes to lungs, and the one soft tissue sarcoma which goes to liver most commonly is retroperitoneal sarcoma. So retroperitoneal sarcomas can go for liver. Otherwise, all other sarcomas, the most common site is lungs. Okay, so please don't forget, when you're operating sarcomas also, please don't forget the lymph node mets is very rare, and only when there is a lymph node mets, we do lymph node dissection. Otherwise, no need of lymph node dissection at all. So it is very rare. Can you tell me what are the soft tissue sarcomas which will have lymph node mets? There is a mnemonic for that. That mnemonic is SCREAM. What are all the soft tissue sarcomas which can have lymph node mets is given by a mnemonic known as SCREAM. Synovial sarcoma, clear cell sarcoma, SCREAM for rhabdomyosarcoma, and Ewing sarcoma, and also epithelioid sarcoma, and A for angiosarcoma, and very rarely malignant fibrous histosarcoma. So these are all the SCREAM. The mnemonic is SCREAM, synovial sarcoma, clear cell sarcoma, rhabdomyosarcoma, Ewing sarcoma, and angiosarcoma, and malignant fibrous histosarcoma. So we are going to discuss about each tumor separately later. Just have an idea about the introduction of these soft tissue sarcomas. Can you tell me what are all the etiological factors? What are all the etiological factors associated with soft tissue sarcoma are? Please don't forget, there is a germline mutation. Always you have to remember, germline mutations associated with soft tissue sarcoma are neurofibromatosis 1, Life-Romany syndrome. I hope you remember Life-Romany syndrome due to P53 mutation, neurofibromatosis 1, and familial adenomatous polyposis producing desmoid tumor. desmoid tumor. Neurofibromatosis 1, Life-Romani syndrome, and familial adenomatous polyposis, which is seen in APC gene, and NF1 gene is chromosome 17q, and P53 is chromosome 17p. So please don't forget, neurofibromatosis is 17q, and P53 is 17p. Okay, P53 mutation is 17p. So these are very important basic things, and this is associated with radiation. One of the important cause of sarcoma is radiation induced. Please don't ever forget this, radiation induced. And other carcinogens are also there in the list. There is a huge list of carcinogens which can cause sarcoma. They are all nothing but thorotrast, polyvinyl chloride, and arsenic.
Discussion with the most important MCQ topic, that is rhabdomyosarcoma. Let me start with this rhabdomyosarcoma because it is one of the favorite topic for institute exams as well as for NEET exam. Let me start with rhabdomyosarcoma. I already told you this is the most common type of soft tissue sarcoma in pediatric. So pediatric soft tissue sarcoma, most common is rhabdomyosarcoma. And please don't forget the most common site of this rhabdomyosarcoma is head and neck. In head and neck, we get in parameningeal sites more commonly. We not get inside the brain, we get in the parameningeal sites. What do you mean by parameningeal sites? They are nothing but nasopharynx, nasal cavity, middle ear, paranasal sinuses, pterygopalatine space. These are all known as parameningeal. That is the most common site, followed by extremity, followed by genitourinary tract, followed by trunk. This is the order of rhabdomyosarcoma. Please don't forget the most important thing. Rhabdomyosarcoma is most common in parameningeal. Parameningeal is nothing but nasopharynx, nasal cavity, middle ear, paranasal sinuses, and pterygoid plate. All those areas will come under parameningeal, and this parameningeal is one unfavorable site. Please remember, it is an unfavorable site of this soft tissue sarcoma. And it has been a repeat MCQ. What are the types, histological types of rhabdomyosarcoma? And you all will be knowing probably embryonal type. This is the most common type overall in rhabdomyo. So this is around 70% of them are embryonal type, followed by alveolar type, and another type is pleomorphic type. So pleomorphic type is the one which is common in adults. The most common type in adults is pleomorphic type. So please don't forget, embryonal type is the overall most common, and pleomorphic type is most common in adults. You should not forget these basic points, and please don't forget this is most common presentation of this is as a mass. It presents in two peaks. One peak, the first peak is it's a bimodal age. The first peak is at around 2 to 5 years, and the second peak is around 15 to 19 years. So there are two peaks of this tumor. First is in the 2 to 9 years, 5 years, and second is at 15 to 19 years. And the most commonly spread by hematogenous, as we have already discussed. They spread by hematogenous, and you all very well know the most common is to lungs. So the most common hematogenous mets is to lungs. So, and there is a pathology MCQ always asked in exams from pathology books. You should not forget on core cut biopsy of soft tissue sarcoma, especially this rhabdomyosarcoma. That is actually an image-based question. I will show you the images from pathology. They will show you a type of cell. What is the type of cell? Can you tell me what is the type of cell you get? The cells will be having strap cells like this. They are known as rhabdomyoblast, known as strap cells. This is an image-based question. Another cell is looking like a tadpole. So they are known as tadpole cells. I will show you both these images in the PowerPoint. Please don't forget, tadpole cells and strap cells are classical features found in rhabdomyosarcoma on histopathological examination, and you may get this as image-based question. And embryonal type can be further divided into two types. One is spindle cell type of variant, and another type is sarcoma botroids. I will show you the image also. Sarcoma botroids will be looking like a fungating mass, and it is very common near the vulva. They will look like a fungating mass in the vulva, and histopathological examination will reveal tennis racket-shaped cells. So please don't forget, they will have tennis racket-shaped cells. This is also a pathology question. So these are not questions from clear-cut surgery. They are pathology MCQs. So strap cells, tadpole cells, tennis racket-shaped cells are all features associated with rhabdomyosarcoma. Please don't forget. And when you come to the management of these type of sarcomas, unresectable tumors, we have to start with neoadjuvant chemotherapy. We give neoadjuvant chemotherapy is given for unresectable tumors, and if resectable, the best treatment is resect. And by chance on resection there is a positive margin seen, means we have to give post-op radiotherapy. So these are all basic management of any other cancer, any other sarcoma. These are the management. Unresectable we give a neoadjuvant, unresectable once you possible resect. After resection, if there is a margin positive, you should go for post-op radiotherapy. All these are basic points you should not forget. So what are the points you should know in prognosis? Or the favorable type, histological type. I'm sure you will be knowing that by this time. That is embryonal type. Embryonal type has a favorable prognosis than a alveolar type. And favorable sites are non-parameningeal. I told you parameningeal sites are very bad prognosis, especially head and neck sites are very bad prognosis. So therefore favorable sites are non-parameningeal, orbit, vagina, and testis. These are the areas where you can get favorable. Unfavorable sites for embryonal sarcoma is extremity and parameningeal. So please remember, extremity is actually a good prognosis in other places, whereas in rhabdomyosarcoma, extremity is a bad prognosis. So please remember, bad prognostic or bad sites are parameningeal. Only for rhabdomyosarcoma, this is parameningeal and extremity. In general, extremity is good prognosis, but here it is bad prognosis in rhabdomyosarcoma. So please don't forget about rhabdomyosarcoma. It's an important topic for your exam. Especially don't forget the strap cells, tadpole cells, and tennis racket-shaped cells in sarcoma botroids. So next one is directly taken from Bailey and Lowe, dermatofibrosarcoma protuberans. This question is an image-based question. You can get. Can you tell me what is an important differential diagnosis for this DFSP? This is known as dermatofibrosarcoma protuberans. The most important diagnosis, it is a low-grade tumor appearing in the skin like a keloid. It looks like a keloid or scar, like an hypertrophic scar. So many times you think it is a keloid or hypertrophic scar, and it is very low-grade tumor, and it will rarely go for meds. And if at all it is present, the most common site of this is in the trunk. That is why many times you will think this is a keloid. So trunk followed by extremity is the order of dermatofibrosarcoma. So dermatofibrosarcoma, please don't forget, it will be low-grade and it is locally seen and it is non-metastatic. No metastasis seen in these cases. There is no metastasis. And what are the clinical features? What are all the clinical features of this? It presents as a nodular cutaneous mass, and the tumor involves dermis and subcutaneous tissues. Dermis and subcutaneous tissues are usually involved. Very important point you should note here is there is a radial extension. There is a radial extension into the subcutaneous tissue, but epidermis is not penetrated. Epidermis is not involved. In dermatofibrosarcoma, this is a dermatology MCQ. The classical point is it is a slow growing tumor. It will go radially into the subcutaneous tissue and it will not involve the epidermis. It will not have involvement of epidermis. Please remember, and the lesion may be present for many years, and that is why it is given a name known as protuberance. It will slowly protuberant from the skin and it will be present for many years. Okay, please don't forget, and they may have satellite nodules also. They may have satellite nodules may be present by the time of presentation, and when you see CD34 is positive, and they may have a T17:22 translocation may be there. So dermatofibrosarcoma protuberans is an important MCQ topic. Please don't forget T17 is 22 translocation and CD34 is positive. And what is the investigation of choice for this case? We cannot take a core cut biopsy, therefore we need to take incisional biopsy. We have to take a incisional biopsy and we have to give a 2 to 4 centimeter margin and we have to resect 3-dimensionally. We have to give 2 to 4 centimeter margin, and these guys have a benefit with imatinib. Like in GIST, this case also will respond to imatinib mesylate. We can give them as either neoadjuvant or also for unresectable tumors we can give imatinib mesylate. It is beneficial for this dermatofibrosarcoma protuberans. So please don't forget rhabdomyosarcoma, most common site is non-parameningeal head and neck. Dermatofibrosarcoma, the most common site is trunk followed by extremities. Next comes liposarcoma, another important MCQ topic for your exams. All these are various sarcomas. Just have an idea about them. So the most common site of liposarcoma, I hope you know, where all the places the lipoma can get converted to sarcoma. Example, nape of neck, thigh, retroperitoneum. This is a classical MCQ from you, for a clinical question from lipoma. Where are the places where the lipoma can get converted to liposarcoma, nape of neck, thigh, and retroperitoneum. So in retroperitoneum, it arises from the perinephric pad of fat. Please remember, it arises from the perinephric pad of fat. It arises, and it is usually a huge, soft, well-circumscribed lesion. Huge, soft, well-circumscribed lesion. And there are many types like well-differentiated liposarcoma, mixoid variant of liposarcoma, round cell variant, pleomorphic type. Like that, multiple types are there. Just have an idea. Liposarcoma can be of multiple types, and liposarcoma is seen in places nape of neck, thigh, and retroperitoneum. And in retroperitoneum, the most common tumor is this liposarcoma. So please don't forget, the most common tumor in the retroperitoneum is liposarcoma. So then I told you about MFH, malignant fibrous histiocytoma. So this was mentioned as the most common tumor in previous edition. Now it is not mentioned there. It is most common in lower limb. So please don't forget, it is malignant fibrous histiocytoma, most common in lower limb, followed by retroperitoneum sarcoma. So then I told you about MFH, malignant fibrous histiocytoma. So this was mentioned as the most common tumor in previous edition. Now it is not mentioned there. It is most common in lower limb. So please don't forget, it is malignant fibrous histiocytoma, most common in lower limb, followed by retroperitoneum, and it arises from fibroblast. It arises from fibroblastic cells. Okay, and it is usually intramuscular. It is firm in consistency, and there are multiple types of malignant fibrous histiocytoma. Please have an idea about MFH. So please don't forget at least 1 or 2 points for it, so that in case you get an exam, no, you can exclude 1 or 2 choices. MFH is common in lower limb, rhabdomyosarcoma common in parameningeal sites, and dermatofibrosarcoma common in trunk. Like that, you keep on remembering. Then comes the next thing: synovial sarcoma. Synovial sarcoma is a misnomer. It does not contain synocytes. Synovial cells are not present. It actually arises from biphasic morphology is present. There is a biphasic morphology present. It arises from epithelial cells and spindle cells. So they don't contain synovial cells. Please remember, they don't contain synoviocytes. They arise from epithelial and spindle cells, and it is relatively common in young age. And the most common site is knee joint. Is seen in 85%. 85% time you get in knee joint. And I already told you they have lymph node spread. Lymph node spread is present in screen, the mnemonic screen, and it is synovial sarcoma is one mnemonic for that. Screen, yes, synovial sarcoma. And the other one is leiomyosarcoma. I hope you know what is this leiomyosarcoma. Leiomyosarcoma is most common in females. It is most common in females. It arises from uterus and then also retroperitoneum. In retroperitoneum, it originates from IVC wall. Please remember, in retroperitoneum, it originates from IVC wall, and in intestine, it is now renamed in intestine as GIST. From the intestine, origin is renamed as gastrointestinal stromal tumors. So among the various points in sarcoma, GIST is a very important topic, and you should know this from GIT. I have discussed enormously about gastrointestinal stromal tumors arising from cells of Kajal. I have discussed enormously in GIT session. Please go on there about this GIST. And what are other sarcomas which are very comparatively rare, or angiosarcoma, which can happen anywhere in the body, and they arise from mesenchyme of blood vessels. So they arise from mesenchymal blood vessels, and there is history of lymphedema. They can arise from history of lymphedema, like lymphangiosarcoma, Stewart-Trevis syndrome, and they can have history of exposure to arsenic or thoratrast. So there are multiple things. So they grow rapidly and they produce systemic mets. Very fast growing is there. Systemic mets are common in angiosarcoma. You should not forget that. And I hope you all know about Kaposi sarcoma, especially in HIV patients. You would have read about this Kaposi sarcoma. Typical image-based question. They will have rubbery bluish nodules. So Kaposi sarcoma is seen in HIV patients. Rubbery bluish nodules are seen all over the body, especially in the extremities. They can happen anywhere, but most common in extremities. They are most common in African people, and they are multifocal. Usually they are multifocal. I will show you one image, and they are usually multifocal than metastatic. We will be thinking it is a metastatic, but it is actually a multifocal, and they arise and they are lined by atypical capillary endothelial cells. Okay, so their lesions may go for remission and reappear. Remission is present. Remission may happen, and again they appear and disappear. And the treatment is radiotherapy combined with chemotherapy is given for them. So the surgical treatment is needed if there is an intestinal or airway obstruction by this Kaposi sarcoma. So another sarcoma is there, which is actually typical AIDS-related Kaposi sarcoma. That AIDS-related Kaposi sarcoma is classically seen. So AIDS-related Kaposi sarcoma is classically seen in homosexuals. Please don't forget, it is seen in homosexual people and not seen in IV drug users. It is mainly seen in homosexual people, and they rapidly spread to nodes. Nodal mets are present. They spread to GIT, respiratory tract. That's what you know. If there is a GIT obstruction or respiratory tract obstruction, we have to do surgery, and it is usually associated with hepatitis, herpes, HHV8, herpes like virus, HHV8 infection is associated with this AIDS-associated Kaposi sarcoma. So please don't forget this point. So these are the various other sarcomas. Just have a few basic points about each. So I have told you rhabdomyosarcoma. Please don't forget, rhabdomyosarcoma is very important. The most common type is embryonal type. Most common type is embryonal type, and most common site is parameningeal site. Okay, please don't forget this. And dermatofibrosarcoma protuberans. It is most common in trunk. They are most common in trunk, and it is a low-grade tumor. It is a low-grade tumor which can grow for a number of years. And please don't forget liposarcoma. I told you seen in neck, nape of neck, retroperitoneum, and extremities like thigh. Okay, and extremities like thigh. So liposarcoma, rhabdomyosarcoma, dermatofibrosarcoma protuberans, and malignant fibrous histiocytoma is most common in lower limb, especially the thigh. MFH is also common in thigh. And then we discussed about leiomyosarcoma, which is common among females, and it is common in uterus and retroperitoneum. It is common in uterus and retroperitoneum. Then I told you about angiosarcoma, and don't forget about Kaposi type of angiosarcoma in HIV patients, and don't forget about synovial sarcoma. Synovial sarcoma is a name is a misnomer. It does not contain synocytes. They arise most commonly in the knee. So these are all just an outline of various tumors. You should not forget these points. Another last, coming to the end of this topic, please don't forget radiotherapy where all it is sensitive, where all sarcomas it is highly sensitive. Can you tell me? You have to remember this point alone. Highly sensitive for what are the sarcomas? Very important. Synovial sarcoma, it is highly sensitive. Highly sensitive. MFH, it is highly sensitive. Fibrosarcoma, it is highly sensitive. So highly sensitive for synovial sarcoma, MFH, and fibrosarcoma. Resistant, where all it is resistant. Please don't forget, when it is rising from gist, it is resistant. Leiomyosarcoma, resistant. And when it is rising from cartilage, chondrosarcoma, it is resistant. So highly sensitive to synovial, resistant to chondrosarcoma. So these are high intensity topics you should not forget for your exams. I'd like to show you the images now. Please see the images. So you can see the typical rhabdomyosarcoma in this baby arising from a parameningeal side, from the nasopharynx side, and you can note in this picture, the classical picture, you can see here the various cells. I told you tadpole cells. You can observe very closely. You can observe the tadpole cells here. You can observe the tadpole cells, and you can observe the strap cells in rhabdomyosarcoma. And you can see sarcoma botroids in the vulva in a baby. They have tennis racket shaped cells on examination. So this is a dermatofibrosarcoma. You can see classically it looks like a keloid, and please don't forget it will have multiple satellite nodules. It will have multiple satellite nodules, and they don't involve the epidermis. So you can see the malignant liposarcoma arising in the retroperitoneum, is a huge tumor. They arise usually from the perinephric pad of fat. In this picture, you can see that they are rising from the perinephric pad of fat, and this is MFH typically seen in the lower limb. And please don't forget Kaposi sarcoma, bluish nodules to be seen all over the body, and these are not metastatic nodules, these are all multifocal lesions. They are multifocal lesions, and that completes the oncosurgery topic. I hope you revise these oncosurgery topics, though they are not so commonly asked topics. Nowadays, when in upcoming next exams, you may need to know everything, a little knowledge. You should have a little knowledge about everything. So I'm covering in depth of this sarcoma. Thank you.